Hello and welcome to another edition of the Neuro-Op Guru. I'm here with Dr. Drew Carey from the Johns Hopkins Hospital. Hi, Drew.
Hey, Andy.
And today we're going to be talking about acromegaly associated with diffuse extraocular muscle enlargement. And Drew, maybe you could just start off by saying why is this important? And I thought thyroid eye disease was the most common cause of big muscles.
Well, I think thyroid eye disease certainly is. Acromegaly is a rare condition, but I think we get patients who are referred to us for proptosis or maybe impaired motility, or maybe they had a scan because they were in a car accident and had some, everybody gets a scan if you're in a car accident, and the radiologist said, oh, diffuse eye muscle enlargement, recommend clinical correlation, see, ophthalmologist or consider thyroid eye disease. And we do see patients in neuro-ophthalmology with acromegaly because they can often and usually have a pituitary tumor. And acromegaly is one of uh, the secretory types of pituitary tumors where they're secreting growth hormone, and the pituitary grows, and that can cause compressive optic neuropathy and a lot of other medical ish complications from it. But they can, as pointed out in this article, develop enlargement of the extraocular muscles. Of course, they get enlargement of all their muscles, so this is not specific, right? They get a lot of growth, bone growth, and other growths, cardiomegaly as well. But the this group of researchers wanted to look at, well, what does it look like? What does extraocular muscle enlargement look like? Is it different than the Graves pattern? Should we be, is this something we can tell apart? Does every patient coming for EOM enlargement need an acromegaly workup as well?
And so what they find, and maybe you could walk us through this figure here.
Yeah, so they looked at 17 patients with acromegaly, which is a lot. We don't have that many coming through our neuro-ophthalmology division on an annual basis, and 18 controls who had non-functioning pituitary adenomas that also had head imaging. And they excluded patients with Graves to keep that out of confounders. It was a retrospective study, and they looked at their CT scans preoperatively and measured the maximal diameter on cross section. So a coronal view and looking at the thickness of the eye muscles. Um, and so that's what they show in the diagram here, that we do have both axial that we're typically looking at. So you can see the optic nerve and the eye muscles, and the medial and lateral recti look big in this top left axial CT scan. And then we have coronal images zoomed in panel B on the right eye, and showing how they would have measured the maximal cross-sectional diameter, height, and width to get you an area. And in panel C, we have a control patient. I think that's cut off, but bottom left, and then bottom right is both eyes of a patient with acromegaly, where you can see there is diffuse and symmetric enlargement of the muscles. And so they compared the four recti muscles, inferior, medial, superior, and rectus, and they were all enlarged in the acromegaly patients compared to control patients. The Which you can get in thyroid, but thyroid usually will spare the lateral rectus relatively. That's the least likely to be involved, the last involved. And so that was different in the acromegaly group. And in fact, they said the lateral rectus was the best distinguishing muscle. It had the greatest difference in maximal diameter compared to the control patients. So the exact opposite of what we see in our thyroid patients. And but the superior rectus had overall diffusely the most enlargement, had the greatest difference in cross-sectional area compared to control patients. So it does look like these are patients, the pattern of muscle enlargement is different than our thyroid patients. And so we can tell that apart using the imaging studies.
And were these patients symptomatic? Did they have diplopia and proptosis, or they scanned everybody?
I think everybody was getting scanned as part of their evaluation. They did not discuss in the article the presence of double vision among patients.
And do you think that's because all the muscles were big? So if all of them are big, they just
I
big
think that's
muscles.
Probably there's two components. One is that it's kind of a diffuse and fairly symmetric involvement. And the second is, thyroid eye disease, we also get a scar tissue development. The muscles become less elastotic. And there's, we classically think, right, you have your acute inflammatory and your light fibrotic stage, but it's probably a spectrum and you get a little bit of each as the disease goes on. These patients, it's growth hormone, it's muscle bulking, it's not fibrotic. So I don't think that the muscles are as stiff and they're going to have as much problem with motility. A lot of patients are diagnosed late because this is a slowly progressive disease. And if you see them every day, you don't see the big changes, but unless they go to like a family reunion where nobody's seen them for 10 years and they go, "Are you my Uncle Bob? You look different." So, it's theoretical they could develop proptosis or in a super severe cases, a compressive optic neuropathy, because the muscles are large and crowding the apex. But because it's slow and we don't get the acute inflammatory exacerbations we do with thyroid, they didn't really report on that. And that would probably be a really rare complication from acromegaly.
So, what do you think the take home message should be for our audience today?
Yeah, so I think the take-home message is if you're seeing a patient with acromegaly and you see muscle enlargement on their scan and it's particularly worse lateral and superior, you don't have to worry about Graves. You do not need to do a thyroid workup for those patients. And if the patient's asymptomatic, don't worry about it too much. If you're seeing a patient that's referred because of an abnormal scan and you do see this pattern, and the patient is asymptomatic, we do need to think about acromegaly because diagnosing that and treating that can save the patient's life. So, and that's what we like to do as neuro-ophthalmologists.
Well, that concludes yet another edition of the Neuro-Op Guru. Thank you so much, Dr. Carey, for that interesting commentary.
Thanks, Andy.